So in this video, I'm going to show you a very simple procedure called as spurectomy. This is the patient's left side nasal cavity, and as you can already see, I'm trying to perform the patient's left inferior turbinate reduction over here. Now I usually perform this procedure by the help of coblation, and I reduce the entire thickness of the inferior turbinate around 90% by keeping the anatomy and the shape and even the bone intact, just the erectile tissue inside I reduced. So you can see there's a spur below. It's a huge spur which was blocking my ease of entrance of the coblator. So I'm going to show you how to do a spirectomy. So this is not a septoplasty or a SMR, just a small spirectomy. This is for juniors who do not know how to perform a spirectomy without tearing up the mucoperichondrial flap. So first things first, take a brown needle and do an infiltration. Now this is infiltration with just a normal saline. You can also take ringus lactate. I do not infiltrate with lignocaine adrenaline. I do not take the risk at all. So you can see that is called as blanching. That is the whitish appearance. This should happen. If this is not happening, it means you are not in a proper plane. This should have a bulge and the entire thing should go white. That is called as blanching. So once you achieve that, it means that you have a good amount of hydrodissection that helps you in your plane of dissection. That's the first step. Second step would be to take a 15 number blade and take an incision uh, on the mucoperichondrium. Now, this incision could be very lower down in the lower half, should not be necessary that the usual incision is to be taken. So I'm starting my incision at the very inferior part of the spur. I'm gonna go superiorly, and I'm not gonna go very high up, just the usual, because I'm not doing a septoplasty, just a spirectomy. So the incision, then you can take your Freer's elevator or you can take your suction Freers and try to do the elevation. So if your height to dissection is good, your elevation becomes really perfect. So that's my Freers suction. So trying to elevate that. So tip over here is that if you do not feel the on your tactile sensation, if you do not feel some kind of roughness, it means there is still a layer above the septum, and it means you have not taken the incision completely. Okay, so in such cases, you can take your blade again and do a gentle incision again, making sure you do not cut through the septum. So I'm going to go ahead, take my blade again, and just with a gentle pressure, take the incision again on the same place so that I elevate the plane even much better. So now when I'm going to use my Freers, I'm going to feel some kind of rough sensation of the cartilage, and that's how I'm going to be sure that I'm right in the plane of dissection. So as you can see now I'm in the proper plane of dissection. You should be seeing proper white color of cartilage. There you can see that's the quadrangular cartilage of the septum, and it should be bright white. If you see something pinkish, it means you still have a layer over it, and you should take an incision and go under that layer. So I always prefer to use my suction Freers because it does the suction and elevation at the same time. So I have done the elevation in the upper half, but then the problem is the lower half where the spur is actually present. Now, many juniors tend to be very haywire in this step. You can see that's the spur. Uh, you have a huge chance that you can rupture your mucoperichondrium there. So you got to elevate all the attachments from the spur from all the sides, but only on the left side, basically. So I'm just going to decongest the area. So I'm going to put the entire patty inside that plane that is between the septum and the mucoperichondrium. So you can see how easily I'm using my Freers, normal Freers right now, and putting the entire neuropathy inside. This procedure is completely safe. It does not rupture your mucoperichondrium. So once I put the entire neuropathy inside, I'm going to give compression from outside as well so that it has a better action inside. I might have to extend the incision below as well so that I can freely, make the spur free from all sides. So as you can see, I'm going to extend the incision down there and I'm going to elevate it further inferiorly. If you do not do this and you try to elevate, the tension in the inferior half of the mucoperichondrium will cause the flap to tear, and we do not want that. So as you can see, I'm just trying to elevate the attachment on the level of spur. Very gently, you can see I'm able to do that. A small layer is still attached. I'm going to elevate that as well. Only after I do this, my flap will not tear. So that layer is gone, and now you can see some bright white appearance. And now I'm trying to elevate the flap from all sides of the spur right now. That's the superior, lateral, and the inferior surface. Once you're sure that all sides has been they have been elevated, you can take the spur out. And in this case, I am not going to take a blade, but with the help of the freers alone, I'm going to do a spurectomy. But for that to happen, you need to be sure from all the sides, posteriorly as well, you need to elevate that. As you can see, all the sides are free from the attachment of the mucoperichondrium. Once I'm sure, only after that, I'm going to take the spur out. So there's no need to go on the opposite side, take an incision on the septum, nothing like that. Just be on one side and take away the spur part. That's it. Little bit of decongestion again. You can see the bright white septum. That should be the appearance of it. Anything pinkish, you are in the wrong plane. And also at the end of it, I never take sutures in the flap area of the incision. I just allow it to rest and pack the nose, and it heals beautifully. No sutures to be taken, not required. I never take sutures unless required. Little bit of compression from outside. Take the patty outside. You can see no bleeding happening right now. And still, remember, I haven't used any kind of infiltration for this patient. So now I'm sure that all the sides are free of the attachment, and with just the help of the freers, I'm going to take an incision on the spur, lateral part, and take it outside. So at this step, just observe the direction of the freers. With the help of the blunt end of the freers, I've taken an incision right there, and I just need to give an inferior lateral push to it, and making sure at the same time I do not give any undue pressure on the mucoperichondrial flap. So with just a gentle push laterally, you can see the entire spur is outside. I'm going to go behind as well, posteriorly, make sure that the spur entirely is outside. With the help of your straight Blakesley forceps, I'm going to take it out. So that is why before taking this incision with the freers, you have to be sure that from all the sides, the spur is detached from the mucoperichondrial attachments. If not, then you can cause a tear on the flap. So a major chunk of the spur is out now. That's the Blakesley forceps. Be gentle. Look at the direction I'm taking this outside. It's a huge part. If you make it horizontal and take it out, that may cause a rupture in the flap. So make it vertical and then remove that. All these minor steps matter in a good surgery. Now I'm going to reposit the flap back and I'm going to see how much of spur is still left. You can see a small part of the spur behind. So I'm going to reposit the flap as I'm doing right now. You can see a huge improvement in the space, but a small part behind is still left. So I'm going to go back in the flap exactly there from inside and I'm going to take it outside. The rest of the spur is out, so that's a good improvement. Same phrase elevator, I'm going to put some pressure on that, take an incision and remove the remaining part of the spur outside. So this step roughly takes around 5 minutes. Nothing to worry about, as simple as that. Keeping the flap intact, follow these basic principles and you'll have your spur outside in no time. So a little bit of decongestion. So you can see that's the posterior part of the spur right there. With a little gentle pressure, you can take away that part outside. Once done, be sure to not put any undue pressure on the flap. So the final step is to check for the correction, and now I can see after reposition of the flap, you cannot see any spur remaining inside, and the space which we have acquired is good enough. So this is how you basically do a spirectomy, and it hardly takes any time to do it. So it improves your passage, your instrumentation, and avoids any undue mucosal damage inside. So now I'm going to continue with my inferior turbinate reduction with coblation, for the video of which I'll be showing later on of how you can do a proper inferior turbinate reduction safely, keeping the anatomy intact for those patients who have chronic nasal allergies and nasal blockage.